Dear colleagues, ladies and gentlemen, my name is Jean-Christophe Bernhard. I'm professor of urology in the University Hospital of Bordeaux, and like to thank the organizing committee to give me the opportunity to present to you some aspects on the use of 3D models to enhance the quality of robotic-assisted partial nephrectomy. So here are my disclosures. So first of all, I'd like to introduce the setting, just reminding you that we have currently on the market several 3D modeling softwares that will apply artificial intelligence to DICOM files in order to produce 3D models. And these kind of 3D models will improve our ability to bridge the gap between 2D and 3D. They may be seen as navigation assistance counterparts for surgery, and we will see in to what extent we can expect to benefit from them from their use. So if we talk about benefits, what do we really want to enhance? In terms of robotic-assisted partial nephrectomy, the goal will be to optimize patient-specific anatomy understanding, optimize the surgical strategy and planning, anticipate the pitfalls, but more importantly, we would like to improve the outcomes of our surgery, and if it is possible, also to improve patients' experience. These kind of 3D models will certainly help us to offset critical situations. And we can simply imagine that more complex the tumor, higher the expected benefit. We all know that when the tumor complexity is increasing, we will have more difficulties in achieving the trifecta. We know that we will have a higher risk of positive surgical margins, a higher risk of prolonged ischemia. We will have a higher risk of conversion to radical nephrectomy or to open surgery. And we will also have an increased risk of intraoperative and postoperative complications. And so these kind of situations will certainly benefit for this kind of tools. So what are we exactly talking about? These 3D modeling softwares will all apply artificial intelligence algorithms for automatic structure recognition and at the same time perform a CT scan segmentation that will be semi-automatic or fully automatic. So what does it mean? As you can see here in this short video, the software will analyze all the slices of all the faces of the preoperative CT scan, and they will create from this 2D slice of the CT scans, they will extract the volumes of interest, meaning the volume of the tumor, the volume of the vessels, as you can see here, that was shown the arterial tree, the volume also of the collecting system, and the volume of the normal renal parenchyma, and everything will be fused in a single model. And you can see here the kind of representation, the kind of vision of the anatomy that we can have, and this is a virtual reality. This kind of software will also be able to predict the volume of the zones of ischemia, the extent of the ischemia, when we will apply a clamping point, and you can select a point, a clamping point, and the software will calculate the ischemic zone. So this kind of models will be of a great help in the preoperative setting when we plan our surgery. And you can see here the comparative vision between a volume rendering display of the CT scan that you can have here on the right side, and on the left side, sorry, and the vision of the anatomy that we can achieve by the use of 3D model. And we clearly see that these kind of models will give us an enhanced anatomical vision of the situation. But these kind of 3D models will not only be used in the preoperative setting for surgical planning, but they will also be used for live surgical guidance. And you can see here two videos, one that is showing how we can plug the computer with the 3D model software in it to the robot console in order to perform a 3D model assisted surgery and intraoperative navigation. And you have here on the right side an example of hilar dissection with the precise dissection of small segmental arteries that were predefined and preselected on the preoperative model, on the 3D model, to be direct feeding tumor arteries and arteries that will be of interest for the rest of the surgery, and especially when we plan to perform super selective clumping. So the questions that we can have in terms of outcomes in using these 3D models can be responded in the literature. The first question would be to know if these 3D models will improve the tumor complexity assessment by the surgeon, and especially the way that the surgeon will be able to use these 3D models to predict the risk of complications of the partial nephrectomy. So we can refer to first publication of Porpiglia's team published in 2019. This was a prospective non-comparative study involving 100 of patients between September 2016 to September 2019. And the authors made a comparative assessment of renal and Padua scoring using 3D models versus 2D CT scan. They also evaluate the predictive accuracy of the 3D scoring, the scoring, either made with 3D model or 2D CT scan, regarding the overall and the major postoperative complications. So what are the conclusions of the authors? First, is that with the help of the 3D model, the surgeon will have a different ability to assess the complexity of the tumor he will have to operate. And you see that in this study, they reported a 50% downscoring of the tumor when 3D models were used in the preoperative setting. The second conclusion was that the best predictive accuracy was achieved with 3D model for both overall and major complications. So meaning that using the 3D model will improve the ability for the surgeon to highly evaluate, to accurately evaluate what the complexity of the surgery will be. Second question is regarding the impact of the use of 3D models assisted surgical planning in terms of intraoperative complications. And we can now refer to this publication from James Porter's team, published in 2019. This study was a randomized controlled trial involving 92 patients that were randomized in two groups, the 3D model assisted surgical planning and a control group in which the surgical planning and the surgical reflection on the strategy was made with the help of the 2D CT scan. The authors compared the intraoperative surgical outcomes in terms especially of operative time, clumping time, estimated blood loss, and finally, they also had a look to length of stay. So what are the conclusions of this study? First of all, the authors reported a benefit on the estimated blood loss and on the length of stay. But more interestingly, they reported that more challenging the case, higher the benefit. Third question, now not only using the 3D models for surgical planning, but also for surgical guidance, live surgical guidance, what will be the impact on using these kind of models directly in the heart of the surgery. So I present you here the results of our study recently published in 2021, where we retrospectively assessed 645 robotic-assisted partial nephrectomies performed by 3 expert surgeons with 2 groups that were compared. The 3D image-guided robotic-assisted partial nephrectomy, 230 patients, and the control group, standard robotic-assisted partial nephrectomy, with a group of 415 patients. So 3D models in the 3D image-guided robotic-assisted partial nephrectomy group were used for both surgical planning in virtual reality, but also intraoperatively, as I showed you before, when you plug the computer to the robot console and use the tile pro function. We compared intraoperative outcomes and postoperative surgical outcomes, and we concluded to a longer operative time when we use the 3D models, but to a benefit on the risk of conversions, either or conversions to open partial nephrectomy or to radical nephrectomy, a benefit on the rate of postoperative severe complications, the risk of transfusion, a benefit in terms of length of hospital stay, and finally, a benefit in terms of trifecta, that is the outcomes that represent most accurately the quality of the surgery that is performed. If we have a look to the functional outcomes, we also reported a benefit on early renal function recovery, and certainly because we had much more ischemia sparing techniques performed in the 3D image-guided robotic-assisted partial nephrectomy. When looking at the trifecta achievement, you can see here that in the 3D image-guided robotic-assisted partial nephrectomy group, we had an absolute gain of 10% in terms of positive trifecta achievement. Finally, the last question was on the topic of patient experience. Are we able to improve patient experience with the use of 3D models? And especially, you all know that today with the use of 3D printing technologies, once we have the 3D virtual model, it's easy to get the 3D physical model and the 3D printed model that will be patient specific and that can be used to improve the personalized patient education. So just referring to our publications published in 2016, where we assessed patients' comprehension with the assistance of personalized 3D printed models. And we concluded in two messages. The first one is, even if we try to accurately explain to our patients what their situation is and what the surgery will be, explaining the risks and everything. You can see here that about 50% of the patients finally do not understand what we are explaining to them. And with the use of these 3D models, 3D tools, we are able to improve by up to 50% their comprehension and education. So finally, in conclusion, you've seen that there are different ways to use 3D models for robotic-assisted partial nephrectomy. This kind of models can be used preoperatively for planning and patient information. They can be used also intraoperatively for surgical navigation as a virtual reality or augmented reality. There is now in the literature a largely proven benefit in terms of implementation of ischemia sparing techniques. And as we reported for the 3D image-guided robotic-assisted partial nephrectomy technique, we can expect benefit in terms of surgical outcomes, especially trifecta achievement, decreased risk of conversions, decreased rates of transfusion, decreased rates of major complications, a better short-term renal function, and finally, decreased length of hospital stay. Thank you very much for your attention.